for you, if you can remember last night or yesterday about the group of agents directly acting on the receptors, especially we're talking here of those that utilize the receptors reserved for acetylcholine. So if you can recall the general effect of the drug belonging to this group of autonomic drugs, basically upon the activation, the receptor can cause usually stimulatory effects. So this afternoon we'll be dealing on the um, a group of drugs whose um, action is the exact opposite of what we had mentioned yesterday. So we have the Cholinoceptor blockers, which block the action of your acetylcholine. And then those that regenerate the cholinesterase enzyme. So this group of agents um, will cause the continuation of the effect of the drugs of the action of the not the action. It will once this enzyme, already the general function of this enzyme is to degrade the acetylcholine. So when this enzyme is uh, activated to regenerate, then it will cause now the increase in the destruction of your acetylcholine as the neurotransmitter. Okay? Okay, nalala. Okay, so generally, we have this classification. The anticholinergic drugs, they are classified into two main groups according to the what particular receptor is being inhibited. So we have the anti-muscarinic drugs, specifically block the receptor, the muscarinic receptors, whereas the anti-nicotinic drugs, of course, they specifically block the uh, nicotinic receptors. And then the anti-muscarinic drugs is in turn sub-classified into either non-selective. When you say non-selective, it can interact on the different types of muscarinic receptors. You know it already that there are three types of muscarinic receptors. We have M1, M2, and F3. Then another group under the anti-muscarinic drugs are those specifically acting on the M1 receptor. So they are referred to as M1 selective blocking drugs. In the case of cholinesterase regenerators, we have only one. Oh, sorry. For the anti-nicotinic groups, of drugs, they are classified to either are acting on the ganglionic area or into the neuromuscular junction. So this is how they are classified as being an anti-nicotinic receptor drugs. Either are acting on the ganglion itself or acting as a neuromuscular blockers at the junction. Then we have the cholinesterase regenerators. We have only one class. We have the oxime, and so basically, again, they are responsible in regenerating the cholinesterase enzyme. Okay, so for anticholinergics or choliноceptor blockers, again, specifically, they act on blocking the muscarinic and the nicotinic receptors for the acetylcholine not be allowed to interact with the receptors. So they are said to be competitive pharmacologic antagonists for the neurotransmitter acetylcholine. So in the illustration, so here when you say when you say competitive inhibitor, they utilize the same receptor in order for the drug to act. So they compete for the available receptor. So here, this green one is said to be the agonist or the real partner for this receptor, but we have a competitive substance that will also be able to interact with this receptor. Okay, then we have the cholinesterase regenerators. So this group of agents, they do not block the receptor itself. So basically, these are chemical antagonists usually seen in organophosphate poisoning. Okay, so these blockers or drugs are classified according to its selectivity in terms of reacting with the receptor. So in muscarinic receptor blockers, we have four classifications. So we have the non-selective blocker. This means that the agent can interact any type of muscarinic receptor. So whether it is M1, M2, or M3, so this particular drug can interact with the receptors. A typical example for this is atropine. Then we have the M1 selective blocker or drug. So this group of drugs specifically interact by inhibiting the M1 receptor. A typical example for this group of drugs is dicycloverine. Dicycloverine, which is this is an antispasmodic drug usually given for those patients having abdominal pain. Then we have the M2 selective blockers. These are group of drugs that specifically inhibit M2 receptors. And One typical example of the drug under this group is galliamine. Then we have the M3 selective drug or blocking agents, and this is exemplified by oxybutynin. Then for nicotinic receptor blockers, again, there are two classification, whether acting on the ganglion itself area or in the neuromuscular junction. So for ganglion blockers, we have one example. We have trimetapan. And then for neuromuscular junction blockers, one is tubocurarine, which is this is usually used in as an anesthetic agent. Okay, so the drugs can also be classified not only according to the type of receptors that they interact, but can also be classified according to its lipid solubility. So we have these two classification. We have the group of tertiary amines and quaternary amines. So with regards to tertiary amines, they are characterized to be well absorbed in our body, and even it has easy access for the central nervous system. So examples of drugs under this category, we have the benztropine, the atropine, dicyclomine, oxybutynin, then we have pyrrenzepine, scopolamine, then down the line. For the quaternary amines, generally, they are described to be poorly absorbed in our body, and practically they don't have CNS effects. So meaning they cannot pass through the blood-brain barrier. So these are some of the examples. We have the common, I don't know if you have encountered this, ipratropium. Usually, this is added with your beta 2 agonist, usually used in the treatment of asthma, your ipratropium. Okay, so again, for the different anti-muscarinic blocking agents, for the different muscarinic receptor blocking agents, so this is just a review of what I have discussed yesterday. So again, it is very important to know the where these receptors are concentrated. So for M1, it is primarily located in the nerves, and the second messenger system that is activated or that facilitate each action are is by increasing the concentration of these two messenger system, the IP3 and the diacetyl glycerol. So example of drugs that prevent the um, action of your muscarinic 1 receptors. So we have atropine, piperazine, sorry, pyrinsipine, then diclocerin, meow, dicyclovirine, and trihexyphenidyl, trihexyphenidyl, meow, yung Then for the M2 receptors, again, they are concentrated in the muscle, the smooth muscle, then in the nerves. So when it is activated, it can decrease the concentration of your cyclic AMP, opening also of potassium channel. So thereby causing polarization of the cell. So under antagonists or those that block the receptor M2, example atropine and also hyoscine and galliamine. So and then for your M3 type of muscarinic receptor, they are concentrated in glands, in smooth muscle, and in the endothelial lining. So each action is by increasing the IP3 protein and the diacyl glycerol. So again, examples that indicate the action of your M3 is atropine and solifenacine. So you can observe that atropine can act in the three types of muscarinic receptors. So, ano't implication niya? It is being non-selective in its action. Magahang na naman. Sorry ha, naghahang na naman akong slide. Oh, okay. So let us now go to, after knowing the different actions or the different receptors acted upon by these antagonists. So we'll now go to the organ systemic effects once these drugs are given to the patient. So in the CNS, it may have sedative effects to the extent that it can cause amnesia, just like in the use of your scopolamine. In toxic doses of these anti-muscarinic agents, it can cause excitement, agitation, hallucination, or even coma. And then it may also exert anticholinergic effect in the brain by by its effect in the basal ganglia. And then also it will decrease the vestibular activity. This is an advantage for those patients who have complaints in uh, motion sickness. So generally, the organ effect on the brain of these anti-muscarinic agents, blocking agents, it can cause restlessness. The patient may be irritable. It can cause hallucination. It may have also an anti-Parkinson's effect and anti-emetic effect. Okay, for the eyes, if stimulation of the pulmonary mimetic, the muscarinic receptors can cause constriction of the pupils. For the eyes naman, by the effect of the blocking agents in the muscarinic receptors, it causes now mydriasis, meaning dilatation of the pupils. It can also cause psychoplegia and ultimately cause impairment of accommodation and may also increase the intraocular pressure. And because of the decrease in the because of the effect in the lacrimal gland, it can cause now sandy eyes. So there is dryness now in the eyes. Okay. For the cardiovascular system, low dose of the antimuscarinic blocking agents, it can cause uh, bradycardia. However, with the use of high dose of these blocking agents, there is a rebound tachycardia because of um, as a nodal effect. So duha iton iya effect, opposite depende on dose given to the patient. So you should be careful. And then for the lungs, it can cause bronchodilation and then also decrease bronchial secretion. And then in this gastrointestinal tract, the effect of these antimuscarinic agents include significant decrease in the motility and tone of the GI tract. So because of the decreased motility, it can increase the gastric emptying time, and there's so-called spasmolysis. So there could also be significant decrease in salivary secretion and slight decrease in gastric and intestinal secretions. For the the genitourinary tract, the effect of these anti-muscarinic agents will cause relaxation of the smooth muscle of the ureter and bladder. So it has the so-called anticolic effect. But please remember that it does not have any effect in the uterus. So bangka mo mahadlok na it may precipitate uterine contraction. So it does not have any effect. In the sweat glands, so the effect will be decrease in the thermoregulatory sweating because you should also remember that the eccrine glands, which is a different group of glands, they are supplied by the sympathetic cholinergic nerves. Okay, so this is just a summary of the effect of your anti-muscarinic drugs or your muscarinic blocking drugs. If you can recall, yesterday I have emphasized it that when there is activation of the acetylcholine receptors, either your muscarinic or nicotinic receptors, you can see a patient that is said to be wet, mahulos. But this time, if you are dealing here with in blocking the muscarinic receptor, then you will see a patient that is dry, and then the patient is relaxed and also with dilated pupils. So it is so easy to recall with regards to the effect of the drug in the different organs wherein the muscarinic receptors are blocked. Okay. So what are the clinical uses for the use of muscarinic blockers? One is for the treatment of motion sickness. So ito nga di rin nakaka-tolerate sinising naton nga mga dagaton. So this is exemplified by your scopolamine. And then also for the treatment of the symptoms of related to Parkinson's disease. So this is for the anti-muscarinic blocker is given to the patient. This for the purpose of restoring the cholinergic dopaminergic balance in the basal ganglia. So under this indication, we have examples. We have benztropine and trihexyphenidyl for the treatment of Parkinson's disease symptoms. Then another one is um, for midrias in dilating the pupils of the patient. So you this anti-muscarinic or muscarinic blocking agents, they are used as mydriatic, meaning they open up the uh, or dilate the pupils of the eyes. This is to facilitate for the in performing fundoscopy. So under this, we have example tropicamide. And then also another clinical indication in the use of muscarinic blocking agent is for the treatment of acute dystonia. Usually, this is observed as a side effect for the use of antipsychotic drugs. So under this, we have example benztropine. Another use is of these muscarinic blocking agents is used as a pre-anesthetic in the employment of pre-anesthetic medications. This is for the purpose of reducing the airway secretion. So para ma-dry. Okay, so under this we have atropine. And then we have for the treatment of asthma or chronic obstructive pulmonary disease. So na-mention adto kanina an ipratropium that is paired with beta-2 agonist. So this is for the purpose of promoting bronchodilation. So we have example, ipratropium and tiotropium. Then other indications, clinical indications include in the treatment of peptic ulcers. So we have perencipine that is coupled with that of PPIs or proton pump inhibitors in the treatment of peptic ulcer disease. So this is for the purpose of reducing the acid secretion. Then also in the treatment of bowel hypermotility and colic problems. So nabuto di tiyan. So it is given for the purpose of decreasing the peristalsis and spasm. So under this, we have examples like your dicycloverine. Usually, this is given among children. Then of course, ang walang kamatayang hyoscine and butyl bromide. Common brand is what? Not common brand usually prescribed that the
Buscopan daw.
generic
Buscopan.
Buscopan. Okay. So Mag-aram naman ngayon ka mo ini. Then also for the treatment of pain that is related to cystitis, or also for the treatment of ureteral colic. This is for the purpose of reducing the spasm. So again, yung walang kamatayang hyoscine and propantheline. And also another indication is for the treatment of irritable bowel, and then irritable bladder and stress incontinence. So, para di rin mag-ihi-ihi itong imong pasyente. So, again, the indication for this is to reduce the spasm and urgency. So, we have the, examples, oxybutynin and darifenazine. But the one that is available in the market, dairy ini nga darifenazine, the one that is marketed by one company. Finazine gyat iton part iti generic name. Okay. Also for the treatment of mushroom poisoning. So the giving of IV atropine is given for patients who has a history of mushroom poisoning. This is for the purpose of counteracting the muscarinic toxicities. And then another indication is in cases of organophosphate poisoning. So this is given, these drugs are given to minimize the muscarinic and nicotinic symptoms. Again, usually we are using the IV atropine. So in cases of organophosphate poisoning because of the malathion, and um, to minimize the symptoms related with the activity of the muscarinic stimulation, we employ atropinization for the patient. Okay, for those who have history also of permanente mahulog sila iton iya palad. So hyperhidrosis. So for the purpose of decreasing the sweat production, so you can give also muscarinic blocking agent. And then also for patients may have problem with regards to the rate, so bradycardic, so you can also give atropine. Okay, and of course for those patients who have history of traveler's diarrhea, you can give PO or oral atropine. Okay, so how will you now address what if there is overdosage in the use of muscarinic blocking agents? So sometimes now, like for example, in employing atropine in patients having out from having in pesticide poisoning. So sometimes ito mo question is when ako ma-stop paghatag ng atropine. So the use of these blocking agents should be used cautious, should be used with caution. So because if you cannot control these agents, pwede tiya ma-extend itong iya effects. So what are the toxicities, the toxic symptoms related with overuse or lampas na ang dosage? So you can have blurring of vision. The patient may be constipated, or the patient may be having urinary retention. Kay kuan man na, di ba, ang reaction is anti-spasmodic. So, wala na lugod makauro ang pasyente, tapos wala na makaihi kay because of overdosage given to the patient. Okay, you can have also dry mouth, and then you can, some patients may have also in increasing intraocular pressure and also intraventricular conduction clots. Okay, then also the patient may have an elevated temperature, body temperature, and this is also observed in atropinization. So we have the so-called atropine fever. So actually, the patient don't have the fever that is typically caused by microorganisms, but because of using substances like atropine. So the hyperthermia that is observed in patients receiving atropine may be due to the blockade of the thermoregulatory sweating, especially in children. Then, because of vasodilation, so the patient may appear flush. Then again, because of the effect in the CNS, the patient may be sedated, or there might be symptoms of delirium or hallucination. Okay, so what are the contraindications in the use of this um, cholinergic blocking agents? So in patients who have angle closure glaucoma, because of the danger of increasing the intraocular pressure. And also, this is not indicated for patients having prostatic hyperplasia or BPH. Why? So may danangani obstruction na nga ni brought about by the prostatic hypertrophy, plus you are giving an anti-spasmodic drug in the form of muscarinic blocking agents. So ano may tatabo? The more that there will be an urinary retention in the patient. Okay. So what about the clinical uses of nicotinic blocking agents? So the ganglion blocking drugs. So here, for example, uh, trimethophan and hexaconazole. So initially, this was used as an antihypertensive agent, but because of the severe adverse effects related in the use of the drug, this is no longer available in the market. Okay. For the for those nicotinic blocking agents, ito may gamit clinically are those acting in the neuromuscular junction. So we have the so-called neuromuscular blocking drugs. So they are classified into non-depolarizing agents and depolarizing agents. So in the non-depolarizing agents, these are the examples. We have the tubocurarine, pancuronium, and atracurium. So this promote immediate they produce immediate flaccid paralysis. Usually, this is combined with anesthetics para ma-relax ito. itong patient. Okay. Again, the second one is the depolarizing agents, like example, succinylcholine. This is an agonist that causes persistent depolarization, flaccid paralysis. Then the third group are the third group of neuromuscular blocking drugs are those um, agents that produce complete muscle relaxation during surgery. So we have the depolarizing neuromuscular blockers. Okay. This is the last part. So after blocking the effect of your acetylcholine, the second group are agents that enhance the degradation of acetylcholine. So we have the so-called cholinesterase regenerators. So under this, we have pralidoxine and obidoxine. So these are chemical antagonists. So the reason itirangaran why or how do they got its name, because it contain this oxine group as part of each structure. So the binding of pralidoxine or the other one obidoxine dislodges the cholinesterase enzyme from the inhibitor. So bagabagat niya yung competitive inhibitor in general niya ang action to that the one that this degrade the acetylcholine. So the regeneration of the enzyme course if aging has not taken place. So this means that um, you for the drug to be clinically useful, you should give the drug early in the course of the illness. So immediately henkuan pala ini pagtikam. So time here is an important factor. So kay nawawara ni action if like for example na kuan na ihan na an kuan an paghappen an incident. So early administration is said to be essential. Okay, so this is how the will this figure will just show to us how the pesticide or the organophosphate poisoning exert its action in the enzyme. Pero para masayunay nala iton action ko din niya is by displacing the organophosphate poison from the receptor para maka-regain back a cholinesterase enzyme. Okay, this is the last slide. So this is just the summary of the different drugs that are under this group of agents, the cholinergic blocking agents. So we have the prototype and then the variants and then other drugs under each of the classification. So for the non-selective, we have the prototype atropine, and then under this, we have the variants. We have scopolamine, dicyclomine, upod na we have that ipratropium, tiotropium, and then the M1, selective, we have the typical pyrinsipine, then that's the prototype. Then M2, galliamine, M3, selective blocking agents, oxybutene, butene. Then for nicotinic blockers, duduhala siya classification, either acting on the ganglion or in the neuromuscular junction. Then of course for the one that regenerate the cholinesterase enzyme o sa lataton the pralidoxine. Okay, I think this is the last slide. Thank you. Do you have any question in the chat box? Aw, nakuan lahir. Naka din chat box na comment lahirahan. Ano ton? Kung anoan akong kanina gi-mention yung mga tambal. Okay? Do you have any questions? Masayo na nila ito niya. Kakulok, anatong nirostorya, mga maghulos. Yan na, kay na-block man naton ang receptor nga kuan, imagine na lawat yan na, basta nga ni masaling kitang muscarinic blocking agent, nagmamamaraliwa. Ito na to, the exact opposite. So, very mapuri. Okay? So, do you have, less than 1 hour na itong lecture. What are questions? Why? Why? Nasabtan ako, Artuge. Okay la, wow. What a question? Basta amo lang itong masayo na ila. Basta I hold you responsible na for the different description of the agents as to its pharmacokinetic profile, pharmacodynamic profile. Okay. Ang akong discuss man yan and mechanism of action of the drug, and then the clinical indications kung haan niya na-apply na atong pagtambal katong mga pasyente. Aray? Okay, walay, maminaw. May question, or Minita, sorry. Nakalaga man ang imo koan. Monitor. Waray? Or nang maturog na ka mo? Sige, masayunay man laton, di ba nasay man la ko nga kung anon mahulos, yan na mamara. Amo la ito. Okay. Okay, wala mang question. So, nagkatsarabot na kita to ha. The exam will be on October 5. I will have another lecture. Wow, Monday. Aga kulop, ita akong lecture ay iyo morning. Microbiology, tapos pagkalauna, pharmacology. Wow, di ka mo to sumhan na akon. Uy, natawa Queenie. Akon niya, puro akon niya na, save nila kay ininkuan. At least matakas ka mo akon, tapos magkamay-adan na luwat ko. Pero, mind you, ako pinakadamong topic sa pharmacology. Kung daon niyo, ako, bisan nga nitong fourth bi-monthly period, akong tanan topics. Pero one good thing to note, dito hirang nakakabawi ito sa estudyante akong part. Dagko gud tira mga grado. Pero amo lagi hapon ito masayangkit na if they can do it, they can do it. Kasi niyo you can do it. If they can do it, they can do it. Okay, wala namang kuwan. Question? Thank you.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you,
Thank
Doc.
you, Doc.
Thank you, Doc.
Una lang. Magdudrungan.
Thank you, Doc.
Thank you, Doc. Thank you, Doc.
Okay na to and the flight nga kuan attendance.
Yes, Doc.
Para
Opo, Doc.
makonsensya ra mag.
Thank you, Doc.
Oh! Hubog. Hubog yung tao. Sige, balit. Bye-bye. See you next week.